Давайте переходим к следующему докладу, если у нас получится подключиться, потому что следующий доклад делают наши китайские коллеги, в частности, доктор Jianhong Chu. Название доклада «Harvesting Chimeric Antigen Receptor T-cell therapy for management and of hematological malignancies, progress, challenge, and our work». Dear Dr. Chen Hu, thank you very much for your participation in our conference, and would you like to start your report?
I will start to give my talk. Thanks a lot for the kind introduction from the professor. Good afternoon, dear colleagues and everyone. I'm very honored to have the opportunity to speak at this meeting. Today, I will talk about the harnessing the Chimeric Antigen Receptor T-cell therapy, the CAR-T, for management of hematological malignancies, progress, challenges, and our work. My talk will cover the following aspects. I will start with the basic knowledge of CAR-T therapies. This slide illustrates the timeline of the CAR-T development. It can be divided into four different stages. The first one is the concept phase. And the most important finding is that the first generation CAR prototype is firstly described in 1993 by Dr. Eshha. The second stage is the prototype iteration, and the main finding is that the co-stimulatory domain is critical for the in vivo function of the CAR T cells. And this is followed by the clinical proof of the concept. During this period, the outcome from many important clinical trials clearly demonstrated the high safety and the efficacy of the CAR T therapies. And this actually paves the way for the successful commercialization of the CAR T therapies in the recent years. This graph displays the process of the CAR T therapy. Firstly, the blood is drawn from the patient to get the T cells, and then the T cells are genetically engineered to express a protein called the Chimeric Antigen Receptor, namely the CAR. And this receptor can give the T cells the ability to specifically recognize the surface antigen expressed on the tumor cells. Then the CAR T cells are expanded in the GMP factory. When they reach the sufficient numbers, they can be directly infused into patients for cancer treatment. This diagram shows the structure of the CAR. And the CAR is generally composed of the four different domains, including the antigen binding domain, and this is often derived from the single-chain variable fragment from a monoclonal antibody. And then this is followed by the spacer hinge region, and then the transmembrane domain, and the signaling domain responsible for the transmitting the signaling pathway. There are 5 different generations of CAR so far, and the generational difference in the CAR structure can be found mainly in the intracellular signaling domain. The first generation of CAR does not have the co-stimulatory domain, while the second generation of CAR and the third generation CAR contain 1 and 2 co-stimulatory domain, respectively. And the first generation of CAR and the fifth generation of CAR is built on the basis of the second generation of the CAR. You can see the inducible IL-12 expression cassette is often included in the first generation of the CAR, and where the IL-2 receptor beta intracellular domain is often included in the fifth generation of the CAR. Compared with other therapies, CAR T therapies have some advantages. Firstly, the CAR T cells can recognize and kill the tumor cells in an HLA and antigen presentation independent manner. Secondly, the CAR T cells can persist for a very long time in vivo, from several weeks to several years, and this can help establish the enduring tumor immune surveillance and help the patients maintain the long-term cancer-free survival. And that is why CAR T cells are called the living drugs. Due to the both advantages, the CAR T therapies display the potent anti-tumor efficacy against relapse and refractory cancers. This table lists the potential CAR T targets for the blood cancers. For B-cell tumors, CD19 and CD12 are often used as targets. For T-cell tumors, CD7 and CD5 are often used as targets. For multiple myeloma, the BCMA antigen is often used. Next, I will talk about the FDA-approved CAR T products. Starting from the 2017, 6 CAR T products have been approved. Among them, the 4 products target CD19 for the treatment of B-cell lymphoma and leukemia. The remaining 2 products target the BCMA for treatment of multiple myeloma. So FDA-approved CAR T products have displayed the impressive efficacy in the blood cancers in the terms of the overall OS, EFS, and PFS. Next, I will talk about the main challenge and limitation of the CAR T therapies. Also, the CAR T therapies have demonstrated the impressive efficacy in the treatment of the different cancers. There are still some of the challenging limitations for CAR T therapies. Particularly, we know that many patients may relapse or develop the resistance following the CAR T therapy. And one of the major causes of the CAR T resistance is due to the antigen loss or downregulation. It's also called the antigen escape. The antigen can be modulated in tumor cells through the different mechanisms, including the genetic mutation, alternative RNA splicing, cell lineage switching, and so on. In B-cell leukemia, it has been reported that about 50% of the patients is related to CD19 loss following the CAR T therapy. And in large B-cell lymphoma, about 30% of the relapses are associated with the CD19 loss following the CD19 CAR T therapy. And similarly, in multiple myeloma, the downregulation of BCMA antigen is frequently observed in the patients following the BCMA CAR T therapy. To resolve the antigen escape, there are mainly the 2 potential strategies. The first one is to utilize the CAR T cells targeting the alternative antigens. For example, the CD22 CAR T cells have been reported to cure the patients with CD19 loss following the CD19 CAR T therapy. The second strategy is make use of the bispecific CAR T cells. It has been reported that the CD19 and CD22 bispecific CAR T cells can be used to treat the B-cell malignancy with the CD19 antigen loss. We also did some work about the identification of the CAR T targets for the blood cancers. Since Ig-beta is highly expressed in B-cell lymphoma, we generated the Ig-beta specific Chimeric Antigen Receptor construct and produced the CAR T cells. We found that the Ig-beta CAR T cells can efficiently kill the patient-derived lymphoma cells in an autologous setting. Then we proceeded to the in vivo test. We found that the infusion of Ig-beta CAR T cells can efficiently eradicate the tumors in 2 different lymphoma models. One is the systemic lymphoma mouse model, and another is the localized subcutaneous lymphoma model. The relevant finding has been published in Leukemia Journal. and the patent has been authorized. We hope to test it in our clinical trial. We also developed the CAR T cells against another antigen used for treatment of the multiple myeloma. We now call it F gene. I'm sorry, I cannot disclose it at this stage. Interestingly, we can find that this F antigen is highly expressed in some multiple myeloma patients with very low level expression of the BCMA gene. The F-CAR T cells we develop have displayed the obviously the cytotoxicity against the multiple myeloma cells. Then we tested in a systemic multiple myeloma mouse model, and we found that the F-CAR T cells can induce the tumor remission in this model, and their efficacy is comparable to that of the BCMA CAR T cells. Importantly, we also demonstrated that our F-CAR T cells can function well in a BCMA knockout multiple myeloma model, suggests that this FR-CAR T therapy may be used as a salvage therapy in the patient with BCMA loss following the BCMA CAR T therapy. We also generated the FBCMA bispecific CAR T cells and found that these CAR T cells can display the superior anti-multiple myeloma efficacy compared with the monospecific CAR T cells. The second challenging limitation of the CAR T therapy is the CAR T resistance in the absence of the antigen modulation, and this is often related to the inadequate CAR T cell potency, a poor CAR T persistence, the CAR T exhaustion, and the terminal differentiation, and also the immunosuppressive the tumor microenvironment, including the tumor suppressive cells and the cytokines. The potential strategies to address this kind of relapse include the prevent exhaustion and the terminal differentiation, increase the CAR T metabolic fitness, boost the antigen sensitivity, and promote the memory differentiation. This can be implemented through the genetic engineering approaches as well as the combination with the small molecular inhibitors. Now I will give some examples. As in this Nature paper, the author demonstrated the authors developed a strategy of the specific integration of the CAR cassette into the target locus by homologous recombination through the CRISPR-Cas9 technique. They further demonstrated that the non-viral PD-1 integrated CAR T cells can efficiently eliminate tumor cells in relapsed and refractory B-cell lymphoma patients without causing the serious toxicity. In this paper published in Cancer Cell, the author demonstrated that the depletion of the BATF also through the CRISPR-Cas9 technique in CAR T cell can enhance the anti-tumor activity by inducing the exhaustion resistance and the formation of the central memory cells. Next, I will give some examples of the combination with small molecular inhibitors to enhance the effect of the CAR T therapies. In this paper published in Science, the author showed that the inducing the transient rest through the treatment with the multi-kinase inhibitor, the definitive, can restore the functionality in exhausted CAR T cells through the epigenetic remodeling. In this paper published in Blood, the author found that the PI3K inhibitor pretreatment can enhance the anti-tumor function of the CAR T cells, possibly by promoting the epigenetic and the metabolic reprogramming. We also did some work in this aspect. We found that the clinically available drug still cannot disclose at this moment. We use this drug to treat the CAR T cells. We found that it can dramatically increase the cytotoxicity effect of the CD19 CAR T cell against the different lymphoma cells. And interestingly, we also found that this treatment can decrease the expression of the PD-1 and the TIM3 expression this indicated that this drug treatment may help diminish the CAR T cell exhaustion. And more importantly, we found that this drug pre-treated CD19 CAR T cells can display the better anti-lymphoma effect than untreated CD19 CAR T cells in a systemic lymphoma model. So this suggests that this kind of drug may be utilized to optimize the anti-tumor effect of CAR T cells, and this study is still ongoing. Here is a brief summary. The CAR T therapies have achieved great success in the blood cancers, and how to overcome CAR T resistance and disease relapse remains a big challenge. Also, the numerous advanced strategies have been proposed to augment the efficacy of CAR T therapies. The clinical validation remains the golden standard. More powerful, smarter, and safer CAR T products can be expected in the future. Our research work is supported by the grants from the National Key R&D Program of China, National Natural Science Foundation of China, and also the NCRCH. I also would like to acknowledge the support from the Sinovac Biotechnology Limited. Lastly, I wish the conference a great success. And dear, thanks a lot for your attention. That's all.
Thank you very much for your very interesting report. And dear colleagues, have you any questions for this report? Sorry, one question. What do you think about possibility of reducing side effects which may be associated with long-term persistence of T cells in the patient?
Excuse me, I didn't hear clearly. You mean how to resolve the side effects from which?
No, especially neurotoxicity associated with CAR T cell therapy. Have you any experience or what do you think about the direction of reducing of side effects, immune-associated side effects of CAR T therapy?
I'm sorry, I cannot answer your question. Can you speak again?
Please, another question.
Dr. Chu, thank you very much for your talk. As far as I know, there are several CAR T drugs that are approved in China. Some of them from Novartis, like Chimeric and Yescarta, but there are also a few Chinese-developed CAR T drugs as well, which are either already being marketed or just approved. Can you tell a bit more about them, if possible?
Oh, sorry. Actually, I mainly performed the preclinical study. And I'm not very familiar with the market of the CAR T therapy in China.
Okay, thank you.
Have you any question? Thank you very much. Thank you.